for the series of the 23rd annual Lefeber Winter Series on Aging. This has been a very successful series that was started 23 years ago by Jim Goodwin, and it is a series that comprises 5 lectures, which traditionally start on the last Tuesday of January, and then continue each Tuesday evening at 5 o'clock, this place, till the end of the month of February. This lecture series honors the memory of Dr. Edward James Lefeber. Dr. Lefeber was a physician who began providing medical care for the citizens of Galveston in 1939. And at that time, he was practicing internal medicine and taught internal medicine at UTMB. Over time, he became more and more interested in geriatrics because all of his colleagues around town were not comfortable taking care of older patients. And so in response, he started to preferentially take in older patients. And he kept working with them until he retired. In the meantime, yes, he became the director. Thank you. He also became the director of the Turners and Moody's House, which is now the Meridian Retirement Community. And right before he died, Jim Goodwin was recruited here to start creating the geriatric division. And after he died, the family actually, in France, endowed this lecture series on aging to honor his memory. So today we are very fortunate to have Dr. Kenneth Langa as the inaugural lecturer for the year's Winter Series on Aging. Dr. Langa is the Cyrus Sturgis Professor of Medicine and a professor in the Institute for Social Research at the University of Michigan at Ann Arbor, and is also a research scientist at the Ann Arbor VA. After graduating from Amherst College with a bachelor's degree in sociology, Dr. Langa obtained his MD PhD degree at the University of Chicago, and then did an internship and residence in internal medicine and also a clinical fellowship in cognitive disorders at the University of Michigan, where he remained as a faculty and climbed up the entire academic ladder up to his current position. He has also held a number of prestigious visiting professorships at the University of Cambridge in England, at the World Health Organization at Geneva, Switzerland, and also University of California, San Francisco. Dr. Langa's research, as you will hear from him, focuses on Alzheimer's disease and cognitive decline with aging. He's the associate director of the Health and Retirement Study, which is a large longitudinal project that looks at how Americans age. And it was funded by the National Institute on Aging and the Social Security Administration since 1990. Is that right? So it's a long-running study, a longitudinal study. Dr. Langa has also been the principal investigator of many other research grants funded by the National Institutes of Health and other federal agencies such as AHRQ and the VA. He's published more than 200 peer-reviewed papers in high-impact journals and 2 books. Dr. Langa has received many honors and awards starting at a very early age. He received a National Merit Scholarship as a student, and was a Robert Wood Johnson clinical scholar and received many other awards, among which the New Investigator Award from the Alzheimer's Association, the Paul Beeson Physician Faculty Scholars on Aging Research Award, and is also an elected member of the American Society for Clinical Investigation and a member of the National Academy of Medicine Committee on Dementia Prevention. So we're very honored to have Dr. Langa today here with us to be our inaugural speaker for the 23rd Lefeber Winter Series on Aging, and the title of his talk is the Risk for Alzheimer's and Dementia on the Decline? Epidemiological Evidence from Around the World. Dr. Langa. Thank you very much.
All right. Great. Thanks so much, Dr. Volpe and Dr. Ottenbacher, for the invitation. It's an honor to be here to kick off the Lefeber series this year. You also saved me from a snowstorm up in Ann Arbor where it snowed about 5 inches yesterday. So thanks for the weather, too. It's been nice to be here. As Dr. Volpe mentioned, I'm hoping to tell you a bit about work we've been doing with the health and retirement study, that longitudinal study that she mentioned, as well as some of our connections here with Dr. Rebecca Wong on the Mexican health and aging study. And I have no conflicts of interest, so here's what I'll try to do over the next 45 minutes or hour or so. We'll talk a little bit about what dementia and Alzheimer's disease are and their societal impact. Some of the important trends in this general term of brain health, sort of how people's brains are working here in the United States and in other countries around the world. Again, tell you a little bit more about the health and retirement study and some of the work we've done with those data, and then some conclusions and future questions. And then we'll have some time for questions if anything I say is confusing or you have some additional questions toward the end. So just to start, to get us on the same page here, these are the latest sort of diagnostic criteria for dementia, published by the National Institute on Aging and Alzheimer's Association back in 2011. So you can see that there's sort of two key issues to describe or to define dementia. One is an impairment in thinking, and to meet the criteria, at least two of these domains, memory, reasoning, some of these other cognitive domains here. So you need to have trouble with a few of these cognitive processes, and importantly, these impairments need to interfere with the ability to function at work or at usual activities. So the key issues are sort of objective change in your memory, so a decline in memory or other cognitive processes, and it's now gotten to a point where those impairments are bad enough that you can't get through the day. You need help getting through the day. As many of the folks I talked with today who are doing similar work and I discussed, it seems kind of straightforward when you just look at it that way, but it's not. These are can be fuzzy concepts, difficult to pick up changes, difficult to say exactly when someone is impaired enough that they can no longer take care of themselves. Much of the work in Alzheimer's disease and dementia has been in trying to develop biomarkers, so blood tests, imaging biomarkers that can give us a sort of standardized way to say that someone has Alzheimer's disease or dementia. That work is ongoing. We'll talk some more about that too. So what are the causes of dementia? It's thought that Alzheimer's disease, the buildup of an abnormal protein in the brain called amyloid outside of brain cells, another abnormal protein called tau within the brain cells, build up, cause inflammation, cause dysfunction in the brain cells. Vascular dementia, as the name implies, difficulties with blood flow to the brain, usually due to atherosclerosis or the buildup of blockages in the arteries that lead to the brain and that are in the brain, and then other causes, less common causes you can see here. But actually, again, over the last 15 or 20 years, what's become much clearer is that it's not as kind of easy or not as clear-cut what Alzheimer's disease is and what vascular dementia is, and that most cases of dementia are actually likely due, especially in older folks, 80 and older, likely due to overlapping pathologies, both Alzheimer's disease and vascular problems, sort of the most common mixture. So this idea of a mixed dementia has become clearer as population-based studies that are following older people and that do autopsies, brain autopsies, have been able to gather this information about sort of what's really going on in the brains out there in older folks. So sort of studies in hospitals or universities where we work, where you kind of pick people that just have one pathology and exclude others to try to understand that one pathology, that's not what's going on out there in the real world, and it's this kind of complicated overlapping and mixed dementia that's important. So just to talk a little bit more about this overlap and interaction of Alzheimer's disease, that buildup of the abnormal protein in the brain, and cardiovascular or cerebrovascular disease. Nature has given us a hint that blood flow is important to the brain. The brain is about 2% of our body mass, but actually gets about 20% of blood flow. So in just very plain terms, it seems that blood is blood flow, and feeding the brain cells with blood and oxygen is very important just from that very fact right there. And then there's also, again, the overlap both in epidemiologic and clinical studies over the last 20 years. It's become clear that the risk factors for Alzheimer's disease and for vascular dementia overlap very significantly. So things like high blood pressure, diabetes, high cholesterol, obesity, sort of the classic cardiovascular risk factors also seem to increase the risk for Alzheimer's disease. And in fact, a paper published just in the last year has shown that having more of those classic risk factors in midlife is associated with more of the amyloid protein in the brains of people in later life. We're able now to image that protein while people are living, not just at autopsy. And there does seem to be this connection between the risk factors in midlife and not only the risk for cognitive decline and dementia in later life, but actually for the buildup of the amyloid protein itself. And then again, in terms of mixed dementia and the interaction of the pathologies, for a given level of Alzheimer's pathology in the brain, the more cerebrovascular lesions in the brain, the greater likelihood that someone's going to kind of have that, meet that threshold of cognitive decline that leads to disability in daily life. All right, so moving on to the social and economic impact of dementia. This is a graph that almost all of you studying aging have seen probably a number of times, lots of times over the last in the last years. And this is just a graph showing the population in the world that's age 65 and older, so sort of the classic definition of older adults. 65 plus is the green line here. And then the blue line is actually the population in the world of kids who are less than 5. So you can see that, just focusing on the green line right now, a huge increase. We're about right here right now. A huge increase over the next 30 years, specifically as the demographics in the world are changing and life expectancy is increasing and the baby booms and things like that. We're going to go from about 600 million people who are 65 and older in the world who are in this elderly category up to almost 1.5 billion. So a huge kind of explosion, the silver tsunami as it's called sometimes, big increase in older adults around the world. And importantly, again, that growth is not being matched by the growth in children. And in fact, we're at a really amazing point in the history of human beings right now. Right about now is where we're crossing, those lines are crossing, and where for the first time in human history, the number of older people in the world is outnumbering the number of kids. And as we'll talk about going forward, and those of you who work in this area know, or those of you who've had a relative with Alzheimer's disease, caregiving and families providing care to those with dementia, the dynamics of that is likely to change as the number of children to provide care is not keeping up with the number of older adults. This is some data from, again, the health and retirement studies, some of the work that we've done with our caregiving data in that study. This is just sort of a basic pie chart where we tried to, using the information that we have, sort of understand what are the conditions that lead to the greatest amount of caregiving, the amount of help that older adults need just to get through the day, their activities of daily living. And again, you can see that our studies suggested that dementia, again, perhaps not surprisingly, is the biggest piece of the pie. About 30% of all of the caregiving time and associated costs for older adults in the United States due to dementia. And then again, perhaps not surprisingly, all of the brain conditions. The brain is very important in terms of a cause for needing care. So things like stroke and depression really driving the amount of care that older adults need. And then to get a better sense of the full economic impact of dementia and Alzheimer's disease, again, we used data from the Health and Retirement Study. This is by a paper led by a colleague, Michael Hurd, at the RAND Corporation, where we tried to estimate the economic impact. The punchline was about $50,000 per case of dementia in the United States. The additional cost for that person over a year was about $50,000, about adding up to about $200 billion nationwide. And again, not surprisingly, back to what I was saying before, the largest sort of chunk of the pie in terms of just the economic impact of dementia and Alzheimer's disease is just the time that families spend providing care. That's really about half the cost. Long-term care in nursing homes representing another quarter, and then other expenses here. So again, just the time that families need to provide to keep people safe, to keep people functioning and getting through the day is really the key issue for the cost of Alzheimer's disease and dementia. So putting together that graph I showed you before with some of this cost information, again, because of the big increase in the number of older adults around the world, and actually especially in low and middle income countries, it's expected that the total number of cases can almost triple from about 44 million up to about 135 million in 2050, with a large increase in cost. The worldwide cost was estimated by some other researchers as about $800 billion in 2015. So because dementia is so closely linked to age, with this big increase in the number of older adults, almost certainly there'll be a large increase in the number of people with dementia over the next 40 years, unless some kinds of interventions can be implemented to decrease the prevalence or decrease the risk of dementia going forward. All right, so turning to a few of the recent trends that we think are important to the health of people's brains, both in the United States and around the world. I mentioned before, getting back to that close link between cardiovascular risk factors and the brain. Clearly, and all of you know this, the increasing prevalence of obesity, diabetes, and hypertension is one important trend that would seem to perhaps increase the risk for dementia going forward. But at the same time, there's been much more widespread and intensive treatment of these classic cardiovascular risk factors. So more people with diabetes and hypertension and cholesterol being treated, as well as those with the diseases getting treated more aggressively. So just to put a few numbers on that, for instance, again, diabetes thought to have increased, or the number of cases of diabetes increased from about 150 million back in 35 years ago or so up to 350 million. Big increase in the elderly population the elderly population with diabetes from about 9% to 21%. Smaller increase in hypertension during this time period, but still trending upwards. But then again, treatment intensity and number of people and the treatment intensity has also increased. You can see some of the numbers here again, treatment up from 74% to 87%, and then control of diabetes increased. Similarly, worldwide, a number of studies have shown that systolic blood pressure has come down about 1 millimeter of mercury on average over the last 35 years or so. Again, in the United States, treatment has gone up, control has gone up. You can see we still have plenty of room for improvement, just about 50% back in 2008. So we haven't, we still need to control a lot more people with hypertension, but the control has improved. Similar trends with the cholesterol numbers there too. And this is a graph from a paper just a few years ago in the New England Journal of Medicine that was looking at the complications of diabetes among patients in the United States. So these is just people with diabetes, not all older adults. But you can see what these lines show are the rates of the common vascular complications related to diabetes. So important things like heart attacks, stroke, amputations, lower extremity amputations due to circulation problems. So you can see just amazing declines over this time period from about say 150 events per 10,000 of heart attacks dropped down to 50, again, between, say, 1995 and 2010. Similar with stroke, amputations. So the implication, or one possible implication of these kinds of trends in complications, vascular complications related to diabetes, is that if there is this close connection between vascular problems and the brain and risk of dementia, it suggests that perhaps there's also been some benefit to brain health during this time period because of both lifestyle and treatment changes during these time period. All right, the other social change over the last 25 years ago that we think has had an important impact or may have had an important impact on the risk of dementia is the big increase around the world in educational attainment. So many more people going to school for longer periods of time. The set of bars on the right side of the slide is in higher income countries. The number of people who get a college education, or the number of 30 to 34-year-olds who complete college, you can see has gone up significantly, doubled in higher income countries. Similar trend in lower income countries, the levels are lower, but same trends over these last 40 years or so in the number or the amount of time people are spending in their youth getting education. The other end of this is college education here, the other end of the education distribution, just being literate, being able to read, has also increased significantly around the world. So people are using their brains more or getting education in much greater numbers and intensity over this time period. So for instance, in the United States, to look at these numbers, older adults, about 50% had finished high school in 1990, up to 80% in 2010. Similar trend in finishing college. And we think that education is protective against dementia, likely through lots of different complicated and overlapping pathways. The one that is of interest is this idea of cognitive reserve, which is the idea that as people go to school or as your brain is challenged really all through life, but especially as the brain is wiring up from birth through, say, adolescence or into your 20s, the way that your brain is challenged actually changes the biology of your brain. That the more challenged that your brain is, the more you're thinking about complex things, the more you're talking with people and interacting, is actually changing both the number of brain cells that you have, but also, importantly, sort of the connections between them, the number of synapses, as they're called, between the brain cells. And that cognitive reserve is something that allows you, as those pathologies, the amyloid and the vascular pathologies, build up in your brain through time. If you've got more reserve, you're able to continue thinking normally for longer periods of time and have a lower risk of dementia. So we think that that's one important potential pathway, but obviously people with additional education have lots of other things that might be protecting their brains or protecting their health in general. So people with higher levels of education are less likely to smoke, usually more physically active. They get into jobs that probably challenge their brains all through life in a greater way than people with lower levels of education. They have different social networks, different wealth. So cognitive reserve we think is an important pathway, but there's also, again, likely other pathways that overlap and interact with these related to education that likely protect the brain. There's also this interesting question of sort of the transmission of education, or the protective effect of education. We did some work, a colleague, Mary Rogers, used some of the HRS data that I'll tell you about in a minute to look at does your parents' education have an impact on your own risk for dementia? And we did find that for women, or if your mother had a higher than 8 years of education in this cohort, the HRS cohort, you had a lower risk of dementia even after trying to control for your own education and other important factors. And again, lots of sort of interest in why that may be, if it is in fact true. Pathways like just the uterine environment, more educated women having uterine environments that improve brain health or brain development. Also lots of interest in the way that moms interact with their kids as they're growing up, talking with them in different ways, using words that have more syllables, which again, the thought being that influences the cognitive reserve that kids have. So I think that's another interesting aspect of this idea of education and its protective effect on the brain. So just to kind of sum up and put this together, I think what I tried to argue here is that we think that there's a number of modifiable risk factors, or factors that can affect your risk for Alzheimer's disease later in life, Alzheimer's and dementia. One study has tried to calculate or sum up what the modifiable risks might, how much of the total risk of Alzheimer's disease, or the total number of people with Alzheimer's disease and dementia in the population is related to these modifiable risks. One study suggested about a third related to, again, low levels of education, cardiovascular risk factors, and depression. So again, by implication, by improving some of these factors, we can have an impact on population brain health and population levels of dementia and Alzheimer's disease. Here's one of the mice at our HRS lab that was randomized to getting lots of education. This is, we think, is one potential pathway where more education, you can see here, leading to less brain risk and longer lives here. All right, so now I'll turn to some of the data that we've looked at from the Health and Retirement Study to try to study this question about trends in dementia risk. Whoops, back here. And again, Dr. Volpe mentioned this Health and Retirement Study that's been funded by the National Institute on Aging since the early 90s. We've been following about 20,000 adults in the United States older than 50. It's performed at the University of Michigan at the Institute for Social Research. We collect lots of different kinds of data that I'll tell you about. We do half of the interviews face-to-face in people's homes, half by telephone. All of the data are made public. Our grant is just to collect the data and put it out there for lots of researchers from all around the world. And because of that, there's been lots of publications by lots of people, not just the HRS group that collects the data, about 3,500 publications, about 20,000 registered data users for the HRS. Again, here's a little bit more about the kinds of data that we collect. The ones in red, which don't show up too well, sorry about that. Probably especially relevant for studying dementia and Alzheimer's disease, things like physical and functional performance. Again, can people get through the day and do their activities of daily living? We do cognitive testing, which I'll tell you about. The family, we ask lots of questions about who's in the house, how much time is spent providing care. That's where those studies came from that I mentioned before. out-of-pocket healthcare costs. We also have links to other kinds of data like Medicare, the National Death Index, Social Security Administration. And starting in 2006, we started to collect more biological data by doing a blood test, cholesterol, again, hemoglobin A1C to study diabetes, and then also in 2012 started collecting genetic information. So we have lots of both social and medical information and biological information on these folks to try to understand this complicated aging process and how it affects the brain as well as other health factors. Here's just to give you a sense of the sort of how the study is set up and the cohort is set up. Data collection started in 1992 just with the 51 to 61-year-old age group, and we've been following those folks about every 2 years since then through 2016, and will again in 2018 and beyond. An older cohort was started to be followed in 1993, but then in 1998 we sort of filled in the age gap between them and have been following this group of 51 and older folks since 1998. Every 6 years we enter a new 51 to 56-year-old group to keep the sample representative and follow these younger folks. So in 2004 and 10, and then in 2016, we entered the late baby boomers, people born between 1960 and 65. And I started working with the HRS group in 1997 when I was 34 years old, and I viewed everyone in the study as really old and ancient and trying to understand these old people, and I became eligible for the study in 2016, so everyone's seeming much more young and spry than when I was a 37-year-old. All right, and also, again, for me, one of the most fun parts of working on the HRS has been the connections with the international partners around the world. The NIA, especially Richard Sussman, who was the director of the Behavioral and Social Research Branch until he unfortunately died a couple of years ago, was really a believer in collecting these kind of data, comparable data in countries around the world. So there are now HRS-like studies, sort of studies patterned on the HRS in about 30 countries around the world. You may recognize this one here in Mexico. I'll talk about Dr. Wang and colleagues' study in just a second, but the MHAS is sort of a partner study patterned on the HRS. Again, studies in England, Brazil, India, and China, and the European Union, again with the idea that collecting comparable data where we can compare aging in these different countries around the world where, for instance, levels of education, healthcare systems, family dynamics are quite different, we can understand and understand better how aging happens, what's the healthy way, or what can we do to increase the likelihood for healthy aging. So as I mentioned, the MHAS, based here at UTMB, started back in 2001 and then collected data again in 2003. There was a gap. And then Rebecca and colleagues kind of picked things up again and have interviewed almost 20,000 or 15 to 20,000 people in 2012 and 2015. We'll collect more data again in 2018, following in a similar way to what we do in the HRS, following this group over time and enrolling new younger folks, following folks again in 2018 and 2021. They've also done some sort of supplemental studies, the one which unfortunately I won't have time to talk about either in the HRS or in the MHAS, the MEXCOG study, and in the HRS we've collected a supplemental amount of cognitive data to try to do a better job of understanding dementia going forward, and we were comparing notes, and we'll be looking at these data for years and years ahead. We think exciting time to be studying this topic and to have all of these new data to look at. So here's how some of the things we collect to try to track brain health in the HRS and in many of the other studies around the world. We do cognitive testing each wave, the telephone interview for cognitive status, which is sort of testing things like orientation and memory, much like the mini mental state exam, although can be done over the phone. Other tests here you can see verbal fluency, number series. We also ask people just to tell us how they feel that their memory is doing. Are they able to do ADLs and IDLs, medications for Alzheimer's disease and dementia? And then all of these, again, potentially protective and risk factors that we talked about, lots on the cardiovascular system. We measure blood pressure, obesity, ask about health behaviors, smoking, physical activity. Because we're linked with Medicare data, we can look at lots of acute medical events like things like stroke and sepsis and bypass surgery to understand how those might affect people's thinking. I told you about the genetics, education, all of these things that I mentioned. One of the key issues that and complexities in studying dementia in the population is that as people decline, they're not able to answer your questions anymore, and it's more difficult for them to be in your surveys. So in order to get a true sense or true picture of what's happening with people with dementia, you need to get proxies or other people to provide information about them. So we have questions that are asked of spouses or kids about people's function, these proxy interviews. And then we also do what we euphemistically call the exit interview. That's for people who've died in the study. We go to their next of kin to try to understand important things about the end of life, their cognitive function, their healthcare activities, advanced directives, and things like that. We also did a prior supplemental study about that was focused on dementia and Alzheimer's disease called the ADAMS study. This was back in the 2000s, where we went and went to a subsample of about 850 people in the HRS and did a very intensive in-home neurologic exam, neuropsychological assessment, really to try to get basically to do what would typically be done in a doctor's office or in a memory clinic to try to get what we hope would be as close to a gold standard diagnosis of dementia and Alzheimer's disease as we could get. And then we used that information, that detailed information from the ADAMS, to try to get a better sense for everyone in the health and retirement study using these cognitive measures that overlapped between the two studies to try to say if you scored this level on our cognitive test in the HRS, you're very likely to have dementia. And that's what, for the study that I'll mention, or I'll show to you, that's how we define dementia in the full HRS study. So again, for this study of dementia trends, what we did was we took the older adults, older population from the 2000 sample of the health and retirement study, and then compared them with the 2012 sample, the 65 plus in both years. We used those cognitive measures and tried to classify people in the same way in 2000 and 2012, and then just compare, were more people, fewer people, did they have dementia in 2012 compared to 2000? And then if there were differences, we sort of used variables that we had about cardiovascular risk and education to try to understand the trends over time. And I'll just show you quickly our results from that study. These are, again, from the 2000 wave in the United States, the 2012 wave in the United States. You can see the age range here. There was about the same age, although in 2012 there was it's not shown here, but a greater proportion of the adults were in the oldest the sort of 85 plus age categories had increased between these two years. The key issue that I mentioned before, you can see this big increase in educational attainment, almost one full year. So people who were 65 and older in 2012 had gone to school on average for about 13 years compared to about 12 years in the earlier cohort. There was also an increase in wealth over that time. And then here are some of the both cardiovascular risk factors: diabetes, heart disease, hypertension increased, stroke stayed about the same, and a big increase in obesity that we mentioned before. And then here was the kind of punchline general finding that we did find what we think was a decline in dementia prevalence between 2000 and 2012 from about 11.5% down to 8.8% overall for the 65 plus population. And that decline, again, I should say the yellow bars are from 2000, the red bars from 2012. We saw across the entire age distribution, not just in any one particular age distribution, but the 65 to 74 and 85 plus, up to 85 plus, a significant decline in dementia prevalence between 2000 and 2012. Bit of a busy slide here, but these were our attempt to try to understand what was changing over time and what might have explained some of this declining trend in dementia prevalence. This first row here just shows what's known as the odds ratio of dementia in 2012 versus 2000. Because the odds ratio is less than 1, that's just saying that the risk for dementia in the later year in 2012 was lower, about 27% lower odds here. When we then adjust for age and gender, about 0.69. Then we added things like education and net worth and race, and changes over time in education was the key factor here. The fact that the 2012 group had a higher level of education seemed to explain a good chunk, or about 9 percentage points, of that decline in dementia risk between 2000 and 2012. And then again added some of the cardiovascular risks here. You can see that stroke and diabetes, for instance, increased the risk for dementia, while higher levels of education was associated with lower levels of dementia risk.
Sorry, your last line, the overweight business.
Oh, yeah. Yeah, so good point. The interesting finding here, which some other studies have found, is that obesity actually appeared to be protective in this study. There was actually an editorial that went along with this, this paper when it came out that focused on that. There's lots of interest and debate about this finding, not just in this paper, but across sort of epidemiology and in aging folks. One thought is that this is that obesity in middle age, kind of sort of 40s through 60s, is most detrimental to the brain. So kind of midlife obesity provides a negative effect both on brain health and actually mortality, but actually people that are a bit overweight or obese in older ages, there may be some protective effect to that. There's also some measurement issues here, what's called reverse causality, that becoming or getting Alzheimer's disease or dementia might cause you to lose weight, so it sort of shows up as in some ways an artifact, or again, it's going in the other direction. So I think there's still lots of work to understand exactly that link. Do the risk factors, the effect of the risk factors, change over your life course? This, again, you can't read the individual lines here, but I wanted to just put our results from the health and retirement study in kind of broader context from, again, epidemiologic studies around the world. A whole number of studies now in the US, England, Europe have found a similar trend. This is a meta-analysis of 14 different studies this is dementia prevalence studies here, incidence studies here. Anything to the left of that vertical line was a study that suggested a decline in incidence or prevalence over time. So you can see most of the studies here more so and more consistently for incidence, new cases of Alzheimer's disease and dementia, than the prevalent cases or the cases that are already there in the population. Not every study, again, this is complex relationships. It'd be unusual if everything were going in the same way. But again, I'd say overall, at least this meta-analysis concluded that there does seem to be a relatively consistent pattern in declining risk over time during this time period, sort of 1990s through 2010 or so. All right, so to wrap up and conclude, what we found here with the health and retirement study, that dementia prevalence appeared to decline between 2000 and 2012, in line with, again, some other findings both in the United States. The Framingham Heart Study found a significant decline in incidence of dementia in their studies during this time period. England, other high-income countries also. We think that the rising levels of education and perhaps this increasing cognitive reserve in the population in more recently born cohorts, I think, may be contributing to this decline in age-specific dementia risk in older adults. Again, better control of cardiovascular risk factors, more aggressive treatment of hypertension, diabetes, we think also might be playing a role. So it does, sort of the optimistic way to put this together is that we can prevent dementia through social and behavioral interventions, greater access to education and schooling, more better health behaviors, things like physical activity and control of blood pressure and diabetes. Although, so what's going to happen going forward? This famous quote from the physicist Niels Bohr, that prediction's difficult, especially about the future. Sort of the unanswered questions that will affect, will these trends, potentially optimistic trends, continue into the future? One key question, of course, is how will population levels of cardiovascular risk factors change in the coming decades? Will earlier onset of diabetes in younger adults, both here in the United States and other countries around the world, kind of reverse this positive trend? What will the trends be like in low and middle income countries where the education trends are different, where the increasing levels of obesity and other cardiovascular risk factors could be going in different directions? What exactly are the quote-unquote active ingredients of both early life and later life education? I've sort of waved my hands here to say education is good. We sort of measure it with the number of years you've been in school, but almost certainly there's certain things about being in school. It's not learning out just algebra that probably decreases your dementia risk. It's what exactly is it about challenging one's brain? How can we do it in an efficient way or a low-cost way throughout the world in low and middle-income countries? Getting a better understanding of what it is about education that leads to lower dementia risk, I think, would be really important and valuable going forward. Kind of getting back to this question of do the most appropriate targets for cardiovascular risk factors change over life course? Is sort of very tight control of blood pressure in middle age, tight control of weight and physical activity in middle age the key issue? Is it less important, or should we be less aggressive in treatment with older adults? Those are important questions that are, I'd say, still up in the air. Those of you in the medical world and treating blood pressure, the SPRINT trial was a randomized trial that came out just this last year or two that suggested that tighter blood pressure control than we've been doing in the past, both for middle-aged and older adults, might be good for decreasing mortality. There's still a question about kind of that more aggressive treatment of older adults for more aggressive treatment of hypertension in older adults. Will that do good or perhaps less good things for the brain? That's an important question going forward. Didn't get into this here, but we have a big interest in trying to understand disparities in both brain health and life expectancy. There's been a big increase in the difference or increased disparities in life expectancy across race, ethnicity, socioeconomic status in the United States and other places around the world. How can we understand that better? How can we mitigate those disparities? Really important questions, I think. And then finally, getting back to that slide of the crossing of the lines with older adults, the big growth in the older adult population with not as much growth in kids around the world, who's going to be taking care of the growing number of people with dementia, even if risk is declining. Again, because of that big increase in the older population, there's going to be more people needing care. Just to end, wanted to identify my colleagues on this paper, Eric Larson at the University of Washington, other colleagues on the HRS at the University of Michigan and other places, also our funder, National Institute on Aging, and the Social Security Administration. Thanks very much for your attention, and happy to take some questions.
Thank you very much for your very interesting talk. And so now the talk is open for questions. Any questions from the attendees, please?
Yeah, there was an editorial from Dr. Sapienza in the paper saying that people typically in the last 2 years of their life lose quite a lot of weight and their blood pressure improves. I was just wondering what your take is, because you've got all this weight.
Yeah, no, I think there's good growing evidence of that, and I think that's one of the complexities of an observational sort of longitudinal study like this is to try to make sure you're not getting this reverse causality, that it's it's something about the Alzheimer's disease process or aging in general where you're getting declines in both weight, sarcopenia, things that people in this room study, as well as changes in blood pressure and cardiovascular dynamics. So I think that is, I believe that that's going on, and again, understanding how that relates to sort of preventing dementia, prior to people's getting toward the end of the life is what we need to do and to try to understand. But again, I think you bring up, we kept talking today about the complexity of trying to understand these sort of lifelong processes, and as they change as people age or get close to death is one of the complexities we have to make sure we understand and deal with.
Yes. Have you heard anything about nutrition and how that could be an impact? Because I know there's the MIND diet, and that could obviously be really beneficial for people that have all those risk factors.
Yeah.
Such a prevalence.
Absolutely. Yeah, I think I didn't mention it here, but we did in the health and retirement study do a food data collection or nutrition data collection in 2013, and did find that MIND diet, which is kind of the Mediterranean diet, similar to that, that we did find, at least in a cross-sectional way, that people who had reported that diet did have better cognitive function overall, so which other people have found. Again, that's just sort of a cross-sectional study looking at that longitudinally. But I guess that I'm convinced that your diet has to have an important impact on, just because it has such an impact on your vascular risk, perhaps direct effect on brain cells too. It just seems like that almost certainly has to be important here. Similarly, didn't talk about environmental factors, the air that you breathe. There's lots of increasing attention and interest in pollution levels in sort of big cities around the world, and again, to me, that almost certainly has to be affecting your brain health, what you breathe in, the sort of particulate matter. So I think again, it's hard to study all of those factors because this is such a complicated, again, lifelong impact. But your nutrition, physical activity, the air you breathe, lead levels, things like that, I'm convinced are also an important part of the story.
Mr. Giovannini.
I saw an interview with the woman who wrote Still Alice, and she was just recently, and she was talking about the impact of learning new things. So it wasn't the educational model that you're talking here, but she said the notion that if you get a crossword puzzle every day, she said doesn't do anything for you. You have to be learning something new.
Yeah, I'm sorry. No, I would. I think that's. I believe that too. I think that makes sense. Again, back to this idea of what exactly is education, or what is challenging your brain, and what are the things that are most likely to keep that reserve and keep you thinking. And I think there's a lot of work in that area right now. I wouldn't say I'm an expert in that, but I mean, again, the idea that challenging your brain or challenging yourself in different ways cognitively seems to make sense. That again, you're more likely to make that additional synapse or connection if you're sort of using pathways that you haven't used before, or that are using in new ways. So I think again, exactly what those things are. Is it crossword puzzle one day, reading or discussing complicated things with friends another day? Lots of research in that area. But again, what I tell my patients is my shorthand is that they should walk, talk, and read, meaning stay active, stay connected socially, keep your mind going. But again, if we could figure out and bottle that the different things that we need to keep our brains active, that would be useful to figure that out.
The other thing that she was talking about was the research into tests, blood tests, and other things that would reveal in your middle-aged cohort, so that you didn't have to simply rely on things like, do they have diabetes, do they have hypertension, and so on, that would indicate. And I didn't hear you say anything about how that might impact.
Great question. I think the interest in finding the biomarkers, the things in your blood, or these new imaging techniques that allow us to see that amyloid in your brain or the tau in your brain. As I mentioned, there's lots of focus of research on trying to make that relationship, because if we can identify those folks who are at higher risk, or through a blood test or through an imaging pattern, that would be very useful. And again, ideally to guide interventions, whether it's medications or other kind of interventions. It is, I should say, it's not. It's a complicated topic. I'm a general internist. The idea of early detection always is good, and I believe in it, but it can be a double-edged sword. Things like for instance, PSA testing, prostate-specific antigen testing, picking up a change in the prostate in a man's middle age, can sometimes lead you to do more interventions or more things than which can cause harm if that pathology, if that change in the prostate wasn't going to affect your life long term. So I think it's important that we need to do this research and figure out if we can identify those people that are at highest risk. But that activity is not without some possible downsides when we think about the population as a whole.
So, Larry, last question. Sorry, and then we can break, and the speaker is going to be here. Let's see the last question.
So, with socialization being such a seminal part of brain health, I'd be interested in your thoughts on how the dramatic change in socialization that's occurring in society affects your projections and your thoughts.
Yeah.
Most notably, how much we use phones to communicate.
Absolutely.
How that has changed our social structure.
Absolutely. I think that's such a great question and complicated one. So I mean, a couple things as you're bringing up the change again in the simple fact of families getting smaller. There's an important sort of change in our social structure that and people living farther away from each other. Just those kinds of connections, I think, are changing in important ways. Which, frankly, I don't know that we're able to know for sure how that's going to affect our health or the brain health. I think the question of sort of changing the way we get information, this revolution over the last 20 years of what we read and how we read and how we interact with people. I have a 21 and a 23-year-old who, even when sometimes, especially my son who's 21, sits around a table with his friends, they're all at a table, on their phones, texting, and they'll look up once in a while and interact. So it is an entirely different way of socializing. How's that affecting our brain? There is one fascinating study by the group at Columbia that looked at sort of using the internet and how that's basically, is it challenging your brain and how is it changing your brain? The punchline quickly is that for people that kind of were computer literate and computer experts, they would sort of give someone a search task to go on to Google or the internet to look this up. People that sort of were comfortable with computers, they sort of lit up more of their brain than when they were just reading this on in a printed form, whereas people who weren't computer literate were getting less interaction. The idea being that the internet can actually challenge you more if you go somewhere, you see a topic, you do a hyperlink there and start thinking about something else. So in some ways, that kind of use of the internet might be challenging our brains more in some ways, other ways not. So I think it's, again, a fascinating, important topic. I definitely don't have all the answers here, but I think, again, has to be important, just how we talk, how we interact with people, and how that's changing over time.
Thank you very
All
much.
right, thanks.
UTMB Health, working together to work wonders.